Welcome to my co-presenter, Erin. We good? You can hear me all right on your end?
Hello, welcome.
Good. So happy to join you here today to talk about this really important topic. I wanted to start on Erin and I's behalf to thank the FAU Center for Autism and Related Disabilities for inviting us together to present on this important topic today for you. And before we got started, in the case that you're not familiar with FAU CARD, we did want to spend a few minutes letting you know who they are, so that if you're interested in more of this type of programming and information, you know where to get it and how to contact it. We also want to thank you, PEPSA, the Partnership for Effective Programs for Students with Autism, that provide this type of programming to educators through FAU CARD. So thank you to both of those agencies for inviting us here. So for those of you who are not familiar with FAU CARD, the Center for Autism and Related Disabilities, which are around the entire state, the one at FAU is what we are on here, clearly, provides expert training, consultation, and support to individuals with autism, their families, and anybody who is supporting them, including in employment settings and in the school setting. They offer their services free of charge, and their vision is to provide this support and assistance with the goal of really optimizing outcomes for this population. Keep in mind that FAU has a service area of 5 different counties, the ones that you see here. And anybody who is a resident here and has a child, or you yourself are diagnosed with autism or a related disability, are able to register with CARD and access those services. So there's a main number, but they do have 3 offices across Palm Beach County and the Treasure Coast, one being in the Boca, Jupiter, and the other in Port St. Lucie. So you never have to travel far to meet with a clinician to get the services that you will need. So thank you to FAU CARD and for all of their work that they do there, and for bringing us together to be able to present on this topic with you today. Keep in mind, there are a number of different services that FAU CARD can provide. They do run many trainings and workshops like the one that you will see here throughout the year on many different topics that are important to this population for those of us who are supporting them. They do a lot of public awareness events, and they also do a lot of referrals and providing of resources to families, to educators, and those to bring together the community to know exactly what is out there and available to them to support. In addition to having some social groups, adult groups that run across those different offices. So if you don't know them and you haven't connected with a CARD clinician yet, it's a good time to go ahead and reach out to them to see what other kinds of services that you can access beyond this training series. So that brings us to today's presentation. So Erin and I will talk a little bit about how we've come together in a shared interest in this research and this topic specifically. And prior to this, we've done a number of presentations, me being previously employed with FAU CARD on this topic over the years, and really now very excited and honored to be able to have the topic and have the insights that Erin, Dr. Lozott, brings to this topic in her professional research and her professional experience, and really the day-to-day of being in the trenches and bringing real lived experiences to the research and the presentations that we give. So I'm very much honored to have her join me today.
Thank you so much. Should I say Dr. Balsamo? Noelle, thank you. We're very excited to be here today. And I think that before we get started, and I want to thank FAU CARD. I think both of us used to be with CARD, and CARD, once you work for CARD, you're always with CARD. There's somewhat of a CARD family. So I'm grateful for this opportunity as well. In looking at the title, Rethinking the Ratios, Improving Recognition of Females with Autism Spectrum Disorder, I think it's important to point out the picture that we chose and talk about why we have this picture on the front of our slides. And our goal today is really to start talking about changing perspectives of people, having people be able to look through multiple lenses, fine-tune the lens in which they look at our females with autism as we're going through even the earliest years of life and diagnostic process. We want to rethink how we look at females And we're going to talk about this when we get further in the presentation, but when we talk about females from the biological sense, not necessarily from a gender, talking about genders per se, or gender biases, or any of the current issues that are surrounding, or topics surrounding genders between men and women right now. And when we look at how we assess, how we intervene, how we support females with autism in our families, we want to make sure we're rethinking how we do this. Historically, we've done it one way, and now we've seen that it hasn't really gone as we need it to. So hopefully today we can give you some information, and you can look at this as a young woman or an elderly woman, and depending on which perspective you want to take will depend on which route you go with us.
Okay. Can you see the box laid over the screen, Erin, before? So I know that the PowerPoint can be seen quite clearly to our listeners.
Absolutely. I think it on my end, it looks, there's nothing cut off, and it looks great. So
great. Then I won't worry about moving that over, other than me being able to see. So let us introduce ourselves so you know who's bringing you this information. So I am Noelle Balsamo, and I'm currently an assistant professor of special education at Florida Gulf Coast University. And in my work there, I'm also a member of the Community Autism Network at FGCU under the leadership of Dr. Anne Marie Connor, which is an interdisciplinary faculty group with a shared goal of dedicating our teaching, research, and service activities to benefit individuals with autism and those who support them across the areas that we support and we service. So if we're trained teaching teachers, we want teachers that are skilled workforce to be able to work and educate and learn from students with autism. If you're occupational therapists or physical therapists or counselors, we want to have a shared language and a shared understanding that a population that's as dynamic of this requires an interdisciplinary approach to supports and services. So I'm fortunate enough to be part of a faculty group there. So when you see the Community Autism Network at FGCU, that is what it's referring to. Prior to that, I was fortunate enough to be the assistant director and a clinical support specialist at FAU Center for Autism for a number of years. My clinical background, I am a board certified behavior analyst at the doctoral level and have worked in behavior specialist roles and inclusion support roles and parent education roles across settings, much of which were in a pre-K through elementary, some middle school settings in terms of clinical practice, in addition to some of the other work on the behavior analyst end. So very happy to be here, very happy to talk about this topic, and very happy to be joining Dr. Lozott in this.
Thank you so much. And so, as Noelle had mentioned, I'm Dr. Erin Brooker Lozott, and my background is that I'm a licensed and certified speech language pathologist, and my doctorate is in special education. And hopefully my primary focus of that degree was in applied behavior analysis, and hopefully we'll be able to become a board certified behavior analyst sooner than later.
Matter of time.
Yep, just a matter of time, exactly. My current role is that I'm the program director at ELS for Autism Foundation, that is housed in Jupiter, Florida, as the primary site of our nonprofit organization. We're a global organization. We have ELS for Autism foundations in South Africa, the UK, and in Canada. But from the standpoint of the mothership of services and our main site, we're housed in Jupiter, Florida. We are a center of excellence. We're a lifespan center. So we serve everyone from our little ones that are coming in not even 15 months of age at our diagnostic clinic, or for our early intensive behavioral intervention, speech and language and OT services, all the way through our adult day training program and work experience programs. And we have rec, sports, arts, and leisure. So I guess the moral of the story is we don't have an age limit at the back end. I think currently our oldest individual is close to 60 years of age. So we have little ones at 15 months, and we have grown adults that we're supporting and living as independently as possible in their later part of their lives. And so I get to oversee all programs no matter if they're clinical or not. And I feel very privileged for that opportunity. My prior life before L's for Autism, I've now been here 6 years. We helped open the buildings and grow the programs here. I was a community manager for interventionist manager, if you will, at the Marcus Autism Center, really studying siblings of children with autism, and prior, as you know, worked for UCF CARD. So I'm very excited to be here and extremely honored to be presenting with you, Dr. Balsamo.
Thank you so much. Okay, so from our title, what we're here to talk about really is this uneven gender, traditional gender or sex ratios that we have recognized really since the beginning, from the 1940s or so, when autism was really being diagnosed and recognized as its own characteristic, its own type of diagnoses. So since then, it's really been understood that there is an unbalanced number in terms of genders, in terms of who is identified, who is assessed, and who is diagnosed with autism spectrum disorder, as well as the related labels and titles that existed prior to 2013, as we tried to get better and better at being sensitive to labels, describing a population without getting making it too difficult to recognize some of the shared characteristics. So since then, there has always been more males than females. Currently, it's still the ratios are that males are diagnosed with ASD 4 times. They're 4 times more likely to be diagnosed with ASD. And there's a number of explanations for that, which really is the focus of this presentation, in addition to what that means for this population of underdiagnosed and underserviced females. But one of the important things to think about this, and we will talk and get on the same page exactly what we mean when we say autism spectrum disorder, so that we're recognizing what these characteristics are that we all conceptualize as autism. But what's really interesting about that, as we've done through the research, and I think is what sparked much of what Erin and I's interest in this, in addition to working anecdotally with families and young girls who are feeling the consequences of late diagnosis and a lack of understanding and recognition in the settings that they're in the research, is telling us that we might not have the full picture of whether these ratios are actually accurate or not, and whether they truly are representational of how many males and females, traditionally assigned by sex, are indeed impacted by ASD. And what makes it even more difficult, as we know, is that being a spectrum disorder, that most of those who are identified do have average or above average intellectual abilities, capabilities. So what we notice in these ratios is that if we dip into the population on the autism spectrum that are also identified with co-occurring intellectual disabilities, now we see the ratios getting closer to one another. At one time, it got closer to 2 to 1, meaning males are now diagnosed 2 to 1 over females, with those who also have co-occurring intellectual disabilities. Some of that will make sense if one is presenting with a cognitive delay or a cognitive disability. It will catch the notice of a parent, of a teacher, much sooner than a child who does not have that same delay across that domain. So that part kind of makes sense. And there's still a discrepancy. There's still, even within that, more males than females that are being identified with this. But then if we shift over into that population, which we do understand is the majority of those who are diagnosed with ASD in that average to above average, now we see that ratio was more like 10 to 1, 10 males to every 1 female. So that really started having to beg the question, what is going on there? So are these ratios actually accurate? Or are we not doing quite as good of a job of noticing autism in females that do not have a cognitive disability? And that question has been posed in research and in practice, and it's really an ongoing process of helping us get to know this better. But that's where we live in the ratios right now, in our understanding of them. So here's our question, and here's the question that's in the research and then what we're here to talk about. Are there indeed less females with ASD? Or do we have a gender bias in how we perceive ASD? Meaning, do we see ASD only when the way we know how to recognize it in the males where we traditionally see it, and we're missing it in the females? So that's generally the question. And where the research is, which is ongoing, it's emergent in nature really as we all get together and really start disseminating this research, like in the types of things that we're doing here, where we're having these conversations of saying, well, are we talking about this in our clinical practice? Are we talking about this in our classrooms? Because the research is telling us that there is a population of females that we perhaps might not capture. But the research also tells us that there is a biological explanation for that. There are different theories. Those are not the ones that neither Erin or I are going to go into in depth here, because the topic here is really helping us all get better at perceiving our own biases and recognizing what the behavioral observations are for autism and the way they present typically, and the way that we know how to recognize them through our own clinical judgment. But it is important to say there are works of Simon Baron-Cohen and many other researchers since that will say that there is a true biological explanation that males are more susceptible to autism than females, just based on the way the structure of the brain is. There's some explanations that the male and female brains for those who are identified on the spectrum are more similar to each other than when you compare the females to the males off of it. And a lot of neuroscientists that are looking into that just to help us get a better picture and understanding so that we're doing a better job of identifying and, more importantly, intervening in a judicious way for anybody who requires our supports and services. So the other side of that is many will think that perhaps females are more protected and they require a stronger genetic load or any of those other pieces to then actually be impacted by what we know is a neurological disorder, a lifelong neurological disorder. So yes, there is an understanding that even with improved understanding of the presentation in females and improved processes and assessments, that there is a real likelihood that it is skewed more towards males and females, that it will be actually present of. But many like Catherine Lord, who developed many things, say that's a little bit, the biology for science of that is a little shaky. We have a little bit more diving into that data to trust it. But for our sakes, we really need to, knowing that autism, there is no medical test for autism, there is no blood test for autism. The way we identify autism, as most of us understand, is through behavioral observation and our own understanding of how that looks and manifests across the settings that we find ourselves in. So what we'll spend our time here looking at are really those two domains that characterize ASD from other diagnoses that can be very similar to them, but often are less known and perhaps a little bit less understood outside of the programs that we find ourselves involved in. So we're going to look at the social communication aspect of that and the restricted interest and repetitive behavior side. So to get us all on the same page, even though many of us know this information, to actually become diagnosed with ASD, you do need to show that you have early and pervasive impairments across both of those domains. You can have impairments or you can have characteristics in social communication, but not really show any apparent impact in restricted interest and repetitive behaviors, and then not qualify for an ASD diagnosis. It's important to note that if you cannot perceive characteristics that might fall under social communication deficits and those under restricted interest and repetitive behaviors, then you would have a challenge getting this diagnosis. So keeping in mind, the social communication side of it is the speech and the language part of it. It is the connection, the social relationships. It's the ability to have reciprocal communications. As we all know, this falls on a spectrum of abilities, anywhere from delayed or minimally verbal individuals all the way to very advanced vocabulary, articulate individuals, but still show difficulties, impairments in their social communication, in their ability to use communication functionally, efficiently, and in a way that helps establish and maintain social relationships, which is what social communication is at the heart of it. That is our tool for doing so. And the same to be said for restricted interest and repetitive behaviors. So generally, we think of this in a few ways. We could look at repetitive physical behaviors, some of which are very familiar to people, like a hand flapping or a rocking might have been a common one, but they can very much look different from one person to another, just as we're sitting here doing our own self-regulation kind of thing to make sure that we're sitting here and talking, right? Individuals vary in the way that they do their own regulation and environment. But with ASD, it's certainly more exaggerated. It's a different way and often maladaptive to helping them socialize and regulate in these environments. So it could be physical, it could be verbal, or as we know, a very common one could also be more of a rigidity in terms of interest and special interests, and a real propensity towards one area of interest is a common characteristic that might be recognized within the ASD population, which is more atypical in focus. So just to get us on the same page, so we're remembering exactly what the diagnostic criterion is for autism spectrum disorder, so that when we're moving forward, we could say, okay, well, where do females fall within these two domains? And which one, or both, or if any, where are we missing this in that large group of females without intellectual disabilities that we could perhaps work with each other to develop a more keen sense of what that looks like? Anything you want to add to that there, Erin?
No, I agree. I think that we've made some progress that we're going to talk about, but we still have a ways to go, and understanding the criteria for autism, especially in the DSM-5 versus the DSM-4, is going to be significant because of some of the changes, right? Like, for instance, talking about that they took out the age range of at or before 3 and put it into the developmental period, which goes all the way through, later years in life, so that if you're in the developmental period, even through adolescence, you would still qualify, versus in the DSM-4, you would not. Adding the sensory component into the DSM-5 criteria has really also allowed for us to be able to look at this in a different way. So understanding autism in its broader sense is half the battle, to be able to then hopefully identify females earlier.
Really, really excellent point. As we're constantly needing to refine our own understanding of criterion and characteristics, it becomes a really important discussion. That if we're not doing that, then perhaps we're doing a disjustice to those who are coming into our settings beyond that. Really good point. Okay, so starting with the social communication domain, we're going to jump right in that side and talk a little bit about that. And one of the main points that we have gotten across in the research and has come across in the qualitative research, we have this new language to describe it, thanks to the many females that have participated in research and in groups that have helped describe what their lived experiences are, so that from the inside, so that we can better recognize it from an observational side. And what we have learned from this is that females with autism have reported that they do something called masking, or often referred to as camouflaging. Now, it's important to say that males with ASD also identify with this behavior, or what some have described as a coping mechanism. But what we're learning is it's much more pronounced in the females with autism, and is one of the major explanations on why even those of us who are familiar in working with individuals with autism and the differences amongst them can still miss it. And that's because one of the coping mechanisms as females is that they're working really hard to make sure we miss that. So through this masking, it's generally an ability, or an increased ability, to mask or hide what they would perceive as their autistic symptoms or their autistic characteristics, those that make them different from those they're interacting with. They're aware of them, excuse me, not what I meant to do. They're aware of them, and they're more skilled, according to the literature and the information we get from this small group of population that are teaching us about themselves. They're more better to hide it. So what happens here is that females tell us that they are able to observe and skillfully imitate what socially skilled females look like when they interact with each other. So from afar, it will very much look like a female has the ability to start a conversation, to tell jokes, to use sarcasm, to play in pretend play. But from this concept of masking, what our females are telling us is the understanding of it isn't there. The ability to imitate it is there. And that's a problem. Another part of that, as we go back to, and Erin will touch on this a little bit more in the future, of when we were a little bit less flexible in terms of gender roles, identification, all of those things. We do socialize typically as a society, or particularly in the societies we live in, those who identify with males and those who identify with females quite differently from birth, in the colors that we give, and the toys, in the way we interact, the way we socialize, and quite frankly, our expectations, because we recognize boys and girls behaving differently. And ASD, in the way it's diagnosed, is largely behavioral. So we're looking for those things. So it's also understood that perhaps females with autism that we don't recognize with autism are not just as more skilled in putting on this mask and socially imitating socially competent behaviors, or I want to say what's culturally accepted as socially competent behaviors in the settings that we find ourselves in. They're also perhaps their behavior is shaped to do so a little bit more than males. For example, we know from classrooms that perhaps female boisterous behaviors or hyperactivity is probably redirected a little quicker than males, just because often it's a belief, or perhaps even a misconception, that males have more energy and females have less. So in addition to the females recognizing and the ability and the skill set, there is also often a shaping of that behavior from young children that says, yes, do that, redirect this thing that stands out too much. So the masking or the camouflaging. The other thing that makes it really difficult, or where females with autism can be camouflaged throughout their early years socially, is because they're able to use some of these compensatory strategies. Like if I go on a playground as a special education or as a teacher, and I'm watching all of my students playing, there are some typical play patterns in early childhood and elementary school years that evolve naturally when adults do not interfere. And often females go to play with females, and often males go to play with males, and their play looks very different. Typically, and hopefully this is changing because we recognize we all have different interests and skill sets and all of that pieces, but typically males tend to play more organized games and sports in these social settings within these structures of schools and playgrounds. And girls tend to be more in peer groups, perhaps having a more of a social interaction or a pretend play interaction, generally speaking. So what we're seeing is if we look on the playground and we're looking for perhaps something that might be a challenge to a female, we're less likely to see it there, because females might be in close proximity to females, and we might not see any of the social communication breakdown that's happening there. We're not likely to see it unless we're looking really, really hard for it, particularly since they're trying hard for us not to see it. Whereas boys will, if a boy separates themselves, or if there's what we've been known as not that parallel play, but not playing with, that tend to be a red flag that we notice earlier with young children that struggle to make that social connection in a typical way, we're going to see that a little bit more. So it becomes a really challenging thing. So if we only go and do a very quick observation of females and we're looking for social challenges, it's not going to be as easy as just seeing whether a young girl actually appears to fit in or not. So flipping to the other side of that, if you recall, so we were talking about the social communication. Now we're going to flip over to that other domain of the restricted interest and repetitive behaviors. Here's where we are in understanding from the research so far on this, that there's a thinking that perhaps females may have less repetitive behaviors than males with autism when compared to each other. There's another thinking along those lines that perhaps our very skilled masking females are just better at masking those repetitive behaviors that are socially stigmatizing or socially isolating and have been pointed out as such to them previously. So there is discussion within research of which one that is in terms of the repetitive behaviors, whether it's physical or whether it's vocal or any of those things. We kind of see in here, it might catch our attention as soon as we walk into a classroom or if we're sitting at a lunch table with somebody. We tend to be able to pick up on those because they do tend to be different than the way you and I sit quietly with ourselves if we are typically developing. So that's one side of that. The other side of that, which is often a very telltale sign of ASD early on, is this idea of having a very specific and bit atypical focus on a single topic that really gets excited and captures attention. Can be a really beautiful thing, okay? But we often recognize that that is a telltale sign in autism because it's very hard to have any kind of back and forth two-way reciprocal conversation with somebody who really, really has a very, very motivated interest to stay on one topic. So we've recognized those in males along the way and have even recognized as a generality, we tend to find some similar topics across similar ages. We recognize young boys who are interested in trains. We recognize that dinosaurs perhaps seems to get attention. Back then, Pokemon, the anime, these things that are intriguing for a number of ways with the gifts that come with this neurological difference. But we've recognized that. What they're seeing in females, or what females are describing is that they don't have less of an intensive shared interest than males. It just tends to be a little bit more extreme, or if you'll forgive the word, almost seem normal at face value, because it's the same kind of things that their peers at times might be just as interested in. The photo here was to really prompt that. Many historically and traditionally, females are very into pink things and might have a huge collection of things of pink. And if they can choose between this or that, they're going to choose the one that's pink. That wouldn't cause anybody to raise their eyebrows or have a little concern about whether somebody had a more restricted interest. But if that female collected only pink things, broken things, had to collect them in a very peculiar way, does not allow you to touch them, wants to talk about them, but you have a hard time even engaging the conversation. Now it becomes a little bit more in that atypical special interest part. But I would have to really delve deep and notice that this is indeed a special interest that is a sign of a different way of interacting with information and the world. But also that it is not going to, in our same way, the science of making friends, the way we understand it is that we make friends through common interests. We work through our cultures to connect through our language to find out what those are and share space together in those that we share. But this is not, and this shared interest for females is not as functional in the same way that it would be for other females, that they could connect. Same can be said for males on their special interest topics. But it's important to point out, because just because there might be a perceived, highly focused interest on a single topic in females, and it's like others in females, we shouldn't be less worried about that if it's interfering with their ability to be socially connected to those around them, and to be able to gather other information when it is not connected to their special interest. So it's still a problem, and we have to look at that. An example, you might even go into that later, but when we're doing our assessments and they're trying to get at whether there's a special interest, they will give some very stereotypical male identification type of example of spinning cars and do they love trains. And yeah, there's no reason females not to like trains, but typically they don't get bought a train for their third birthday. So keeping in mind, there's a very atypical, hyper-focused, often different angle of that interest. They might have the same obsession with a boy band. Is that a thing now? Or singers? I'm not going to pretend to give examples because it shows my age every time I do. But instead of just the music, they're interested in the dates in which it was produced and the tour dates and what was missed. And a lot of those pieces might be just as interesting to others, but not typically as interesting to others to that degree.
Noelle, I just wanted to make a comment, if you don't mind.
Yeah, please do.
Because hearing everything that you're saying, obviously, I live this and breathe this, we've studied this, it's so hard sometimes, especially during that assessment piece that I know we'll be talking about. If you only meet a girl one time, or you only meet a girl for a short amount of time, because if, let's say, horses or, Barbies are their favorite item, or one of the new pop stars or the band, like you had mentioned, and they tell you about it, but you only have 15 minutes and you only hear it one time, right? I think that this is sometimes where we fall through the cracks of identification, because in that moment, if you don't have the opportunity to then see another person come in and the same exact conversation happens again, right? Or that toy carries over and nothing is different with any other way in which you play on, session 1, session 2, session 3, it could look like robust imaginative pretend play if you've only seen it one time, because our girls are so sophisticated at really integrating these restricted interests into their play skills, into their conversations. So you need repetition to be able to identify the restricted interest or the repetitive behavior, right?
Yeah, really, really excellent point, particularly because they're careful of giving any diagnostic label that will describe somebody. It's important we look at what's pervasive across settings, across people, and is repetitive and not a single instance. And they could be very skilled. You're right. And intriguing and interesting and charismatic and all of that piece. Yeah. And we don't necessarily get to observe the distress that special interest also can cause when it doesn't go in the way that they are most comfortably engaged in it. Perhaps not easily shifted off the topic. A rearranging of objects that you weren't aware had some kind of method and care behind it. Even touching that can throw somebody into distress because we misunderstood where that interest was. It wasn't just pink, it was a combination of 12 shades or examples like that. And without being able to spend that time knowing that, only those closest to these individuals are going to be able to recognize this.
I think that's where we'll talk about what type of changes we have to have in the questions that we ask.
Yes, very much so. So, just talk about this. So I talked about this. I don't have to say it all that much, but that's where the research was with that, is that perhaps females have less behaviors, particularly the motive behaviors that are going to catch our attention because we can observe them. But perhaps that camouflaging or that coping mechanism that we find our females more skilled in are just able to better mask them in the settings in which they would be the most apparent. The other part is what I touched on, is when we're asking about these things, we're just using very typically male conversations and questions because that's what we see in our experience. And that's the language we're used to saying. And we want to ask the questions that hopefully will get to, have you seen this before, to people who don't know what they're looking for. So it's not necessarily intentional, but it's something we have to be mindful of, that there is an inherent bias to the way we even talk about these characteristics across behaviors. So there's the question and where we are. And often a little bit of a pushback and an understanding perspective that we want to present before we move on. And some of the thinking in terms of labeling which we know provides access to, first of all, insight and understanding to things that perhaps we would not understand about ourselves as being different without it. But it also provides us access to services that can help us be more successful in the settings that we find ourselves in and that we want to be in. So one of the things that often might come up in these trainings and these webinars is that if it is more subtle and they naturally develop these coping mechanisms, why are we bothering to talk about giving them a label at all? And it's really important to get that perspective kind of out of the way, because we do know about how the description, labeling, if you will, helps provide that understanding of behaviors so that we can better inform our interventions with females in the same way that we are working so hard to do and refine for the males that are receiving these support services as they move through. So another really important part of that is that this strategy is really going to be short-lived. This coping strategy of being able to socially imitate social behavior and do it well breaks down. It is not a reliable coping strategy. As we all know, as we age, social behaviors and social interactions become increasingly more complex. Our communication comes increasingly more complex. Our interactions come and they become more subtle as well, as we've started to be socialized on how to interact with each other in the cultures that we live in. Not true for females with autism that are not diagnosed, because that we don't know yet that their social perceptions and their perspectives might not match what ours are typically, or that their behaviors aren't communicating to us that they understand where we are, what we're thinking, where we're coming from, but rather their behaviors are communicating to us that they know what to do or how to look or what to say. So we do know that about the time of adolescence that this masking becomes trickier and trickier. And I won't want to say beneficial because I don't know that it was ever beneficial, but it certainly was helpful to females to get through and to adapt. It's no longer in any way not just eluding diagnosis, but it's not adaptive in any way because it starts to hurt more than it can help females. We know also that females with autism, first of all, we need to say across the board, mental health challenges across autism. If we have difficulty communicating and connecting and being able to refine our behaviors to connect with those around us, we are going to have higher levels of stress and distress and confusion and all of those behaviors that we do when we want to show people we're struggling. So that's a very common thing with this population in males and females. But even when compared to females who have been identified with males who have been identified, the rates of anxiety and depression and some of those comorbid pieces that Erin will speak to in more depth in a few minutes are higher. And there's some pretty high stakes for the females, and we'll talk about why that is. So an important thing to say is even though we have a compensate, like you wouldn't necessarily have to give somebody who has crutches any other thing if the crutches are working. That crutch will fall out, it'll be kicked out, it's not functional, and what some could argue at some of the most important social development years of somebody's life in which they're forming their own identity in relation to their social group and network around them. So that's an important part. The other part, before we switch over to the lead presenter part of it, is this concept in the literature tells us, okay, so females are better at this, but there's also this thing that's happening called diagnostic overshadowing. And generally what that means is, as Erin was saying earlier, ASD is such a spectrum disorder with so many differences that we are constantly learning from in order to describe better, that their characteristics can be very difficult to find, but they also are often overlap with many other co-occurring types of conditions that might occur with autism, but it also might occur independent of autism. Not everybody with an anxiety disorder has a social communication challenge at the heart of that. If you are diagnosed with ASD, you do have a social communication challenge in one way, manifesting in the way that it does from that individual. So the problem is this coexistence of disorders with all of these overlapping symptoms. But additionally, many of these anxiety disorders and OCD and all of obsessive compulsive disorder and all of those other pieces are often more familiar to the service providers that those who do not have recognized developmental disabilities find themselves being treated by in the mental health, in the pediatricians, and the doctors. There are conditions such as anxiety and depression and ADHD and these other pieces that are more familiar to them because they're more highly occurring and their behaviors are more recognizable and reported and all of those pieces. So what we're finding is it's not that we're missing females, but we're diagnosing them under different labels and that are not capturing the heart of what we know is the core struggles and impairments that characterize ASD, which are not just perhaps showing behaviors that might be compulsive or obsessive, but at the heart of that is a social communication breakdown, and that perhaps it's a coping mechanism for it, amongst many other functions that our behaviors might serve for that. The other thing about that is so many females have more internalized and externalized behaviors that do have the diagnosis of ASD, meaning self-injury would be, or eating disordered, all those pieces, as opposed to aggression, which clearly in a classroom, a student who's acting out with aggression is going to be way different than one who is doing social withdrawal from severe depression. It's not going to be as recognizable. So for all of these reasons that we've talked about so far, we may be capturing what we recognize is a vulnerable population, but we're not recognizing what their core vulnerability is, that social communication deficit. And if we're not doing so, then we're not able to help with new coping mechanisms, recognition, and informed interventions for those areas that females are looking to improve in order for their own well-being and success. So I'm going to turn that part over so that Erin could talk more about what this really important part of where our girls, as I think in the literature, I forget who said it, are hiding in plain sight and why all this matters.
Thank you so much. So common co-occurring and overlapping conditions, and what you saw in the slide that Noelle just presented on this diagnostic overshadowing is pretty much what you see in most girls as they go through their beginning years of life. You see by the time most girls are diagnosed, for no other better words, it's almost as though they have alphabet soup next to their name, right? We have everything from, oh, well, does your child have any diagnoses so far? Oh yes, she's been diagnosed already with depression, anxiety disorder, obsessive compulsive disorder, ADHD, inattentive type. Depression, by the way, was major depressive disorder. Oh, someone thought that she had bipolar disorder or any other type of mood disorder, borderline personality disorder. Then you do see, you know, the eating disorders, and you see some other things that come out of this that are more internalizing, that are well masked, like cutting behaviors. And then obviously from all of this, these suicidal ideations, because why me? How I understand so much about how different I am, and I can look at this crowd of people, and I can, as one of the adult females that I know has so eloquently told me, I can watch other females and, as Noelle, you said, imitate them. I created an algorithm for my imitations. It's almost as though it's a science experiment that I can replicate over and over again and get the same results, right? I watch this, I do this, and all the women do the same. So it's very black and white, it's very literal. But when I go to try on my own, without this exact imitation with the group, then I fail. And so I develop these social, emotional, negative memories, right? Mm-hmm. That then kind of pile on top of each other, that then lead me to think, well, if I'm never successful at something from my own perspective, then why? And I always fail by the social expectations in this culture or that culture of these groups, then how could I feel happy about that? And why would anybody even want me? So then the self-deprecating thoughts start. And so then typically what happens is we go into the concept of, therapies, and then the therapist, what do they know, and the interventions in which we try. So you can imagine all of this happens. What this doesn't show you, that we're going to talk about when we go into the next slide, of implications for females with autism and all of these co-occurring overlapping conditions that somewhat on their own mask the core weaknesses of females, is that there are also learning needs that come into play that often don't even get assessed. And then if we don't assess them, we don't know they're there. So how do you ask about something that isn't present, right? That you can't see? You have to know to ask about the invisible, assess the invisible. And then when you see that, that's where we really get to see what we'll talk about of these executive functioning and learning needs that impact. And why does the masking no longer work as a compensatory strategy once we get to that third, fourth, fifth, and so on grades in adolescence? Why does the sticking factor kind of come unglued for the females, in which we hope to serve more? So let's talk about implications. So implications for females living with autism is that without a shadow of a doubt, I think we've well established, and the research shows that they are under-identified, although possibly we're getting closer to having similar ratios as the true ratios are similar to maybe 3 to 1 to 4 to 1, even though, they've gone 2 to 1, they're back and forth with the data there. But our girls, for no other better term of it, are definitely under-identified and diagnosed later in life. And they actually require more intervention and more, they have more severe symptoms often than their male counterparts, but they're not getting the diagnoses because it's not matching the criteria or the lenses in which we're looking. So they have to look more impacted to get a diagnosis early on. And if our girls are coming in and they're coming into a diagnostic assessment and they're saying to you, "You're so beautiful, I love your hair, do you want to see my Barbie doll?" And their language is fluent and they're conversational in nature, and you say, "Oh my gosh, yes, thank you. I can play with you all day long." And then they say, you go to take the Barbie and they say, "I'll do it for you." Right? We call this polite noncompliance, polite controlling behaviors that you don't even know they're leading the ship like a CEO of a large company. At that point, maybe if I'm not versed in girls with this type of profile, I'm going to say, "There's no way she's looking at me. She's reciprocal. She's conversing. I can't check these boxes." So then possibly this is not autism. Maybe she's so social. Maybe she's a little shy. She's highly gifted. Oh, she's wonderful. I like her so much. I want to spend all day with her, right? And now autism is almost kind of in a different box right away, right off the bat, unless I come in, like Noelle, you had mentioned, with intellectual disability or any type of behaviors that are of concern to somebody, or really just severe autism or classic symptoms that we would see in males. We may not be able to kind of send this child off saying, "Oh yeah, we're using the word autism today." So in this case, then we're not going to see referrals, or are definitely eligibility for our Part C or early intervention, and Part B or 3 to 5 school-based services, or even early elementary, are not going to find a way with the criteria currently set to determine eligibility for public school space services. So, well, she's passing the language measure, can't check that. Her speech is intelligible, can't check that. Her intellectual abilities are solid, can't check that. She's not getting in trouble at school. Actually, she tries to please the teacher, and she definitely follows all the rules. She may even call out when somebody doesn't follow the rules, as though she'd be a perfect person to do, a safety guard job, right, at school. And so why would I ever give her a service again? She's getting pretty good grades, kindergarten, first, second grade, and then we're not going to refer. So teachers are less likely, especially general education teachers, to refer girls than boys for testing, possibly due to, if they're not going to have behaviors, they may just be socially withdrawn. Maybe she's tired. Maybe she needs more support. Maybe she's sad or shy. It's okay. She's quiet. And I'm teaching, she's not a disruption in the class. There's no reason to refer. That's not going to be necessarily a red flag of possibly a mental health issue or anxiety or depression. It's hidden behind the scenes. It's not outwardly in the front of kind of on stage for a teacher. So then the teachers miss more symptoms in girls than possibly a skilled clinician that knows how to look at this, or even the parents who are probably saying, "I really want that conference with you." And the teacher saying, "But why? Why do you need a conference? She's doing fine here. What is fine truly defined as, right? And the mom is saying, or the dad is saying, we really need to meet with you. Will you please meet with us? We feel that there's something wrong. And this is the story, I think, of most parents of females.
Can I add to that, Erin? Because it's such an important point that you're saying, is to illustrate what that might look like in a school. And your example of the females, and then also the flip side, oh, they're polite, they're just so sweet and charismatic and kind. And then the other side of it is, if we are socially abrupt in any way, we interrupt because we're not skilled at the social reciprocity. We answer questions that are meant to be rhetorical, and it looks like we're being sarcastic and funny. And then our daughters are labeled with being rude or disrespectful, as opposed to just not having that part. So it's a lose-lose almost situation. Yeah. And then for the parent coming in requesting that conference, I'm so glad you put there. Many parents will feel very relieved to be told there's nothing wrong, whether it's in a clinical setting, to talk me out of this. Let me know my instinct is wrong, and perhaps until things get a little bit worse, not be able to come back to that. Yep. Or be told in that conference, well, your child really could use some manners.
For sure. And that's such a good point. I think recently I had a family that had sent a copy of a disciplinary action form for an adolescent girl that was being disrespectful and disruptive in the classroom. And it defined as looking towards the door and not responding to the teacher or telling the teacher that she was wrong. And so that was sent in because the part of the form was that the young woman had to write the description of what she did wrong, if she apologized, and what she will do differently the next time. And we giggle because we've had these experiences and we know that the outcome is, I didn't do anything wrong. There's no reason for me to apologize, and I'm not going to do anything different because the person was wrong, not me. And this is then when we get into girls and the perspective taking skills that maybe aren't there, that we're not seeing until these moments come. But typically we're not having teachers go through what I would call social autopsy and break down the problem and see where those gaps are. And so teachers, are reporting no concerns with conversational skills because of if the girl can engage in this conversation, whether it's positive or negative, right? In over 50% of girls with ASD, and the clinicians are even saying, well, maybe only at 17%, so even those skilled clinicians, I believe you mentioned earlier in the talk, are not always recognizing when the clear signs when the masking is so great, or they don't see it enough to really define it as let's say a disorder, for no other better term. Mm-hmm. So then continuing on our train of implications, right, for these unique neurological differences in our females is that they're going to be undertreated. They're denied access to early intervention services because they're not impacted enough. They don't, like you said, show the severity of the symptoms that are needed for someone to flag them as needing services. What would I even target as a goal, right? Because if you're rude, you're rude. You just need manners and possibly better parenting. If you're kind and sweet and shy, well, maybe you need more comforting and support, possibly at home. Maybe you're not getting enough love, right? And these are these misconceptions or myths of the world. And then it takes you back to years when autism first started, with all the different theories that we've clearly thrown out with the baby in the bathwater, right? That are just so false, these false beliefs across the board. We're going to be in inclusive settings without support. And then obviously what you're going to see when the information becomes socially abstract, when there's too much planning and too many different problems to solve that really go into the executive functioning skills that our girls don't have the prerequisites for, that they're not doing by themselves without support. Then you finally at that point see the grades start to take a dip, even if we're highly, highly intellectually able and have the language. This is when the masking or the camouflaging breaks down. So now we're making it through possibly, and if we're really bright, possibly all the way through the beginning of adolescence before there's any concern academically. were underrepresented in the research. So now I go to look this up and I want to learn about it. And I think that one of the most intriguing exercises that I've gone through recently is us planning this talk and having to update references and realizing that possibly 3 or 4 need to be updated, but we don't have a lot to pick from. And so this is definitely a population that's still underserved in the research world that we have to continue to look at. And that the evidence-based practices that we have, even up to 2020 with the National Professional Development Center, they're really established based on the efficacy with boys and not with girls. And so despite the overlapping symptoms, the interventions focused on these co-occurring disorders and isolation, we're really, as you had mentioned, neglecting the social communication deficits that are truly core to autism and that are really what's going to continue to have our girls have less successful interactions in life and promote these co-occurring disorders like the depression, anxiety, really make them become more robust, because we're not targeting the center of the disability. We're targeting the noise around it or the byproduct of it. And, we look at autism and we figured out when we don't have early intervention for young children with autism, that oftentimes cognitive deficits were never needed to be there. They were a byproduct of the gap in intervention. But we're still not really wrapping our heads around the fact that if we don't diagnose autism early on in girls, that these co-occurring, which comes first, the chicken or the egg, right? These co-occurring disabilities of, I can't do this, and I know I can't do this. I see I can't do this, and so I become anxious and I become depressed. And where does this end? That these are going to become bigger with life, and the coping mechanisms are going to become less because I don't have coping skills. My coping skills definitely correlate and align with my social communication skills. And if my social communication skills are down here, even if my language and cognitive abilities are up here, well, then I'm going to break down. And so if we don't have information to share with professionals and parents about that, then we're going to continue to see an undertreated population that is not having the positive outcomes I know that they could have if we change things. So
before I move to the next slide, being a PEPSA presentation, we want to make sure that you get your credit for participating in this. So I know that there is a code that you'll want to write down. So I will share that with you before proceeding the slide for Erin. And that code is 1 ONE. It's capital. I don't know if they're going to be that specific, but it's capital O, capital N, capital E, 102021. So 1/10/2021. Okay.
So our population of girls are really what we consider an at-risk population, and the risk factors that you really see that are on the rise as our girls get older and are later diagnosed without intervention, that are underserved, undertreated, underidentified, are the vulnerabilities that put them in place to have increased bullying, whether it's microaggression, microbullying, macroaggression type of macrobullying right in your face. And now in today's day and age, the social media bullying is just unbelievable. I know we're going to talk, Noelle, about the trainings to come, but I'm really excited in this campaign to educate people, professionals, individuals with autism, parents about females with autism, that Dr. Kim Spence is going to be doing a few sessions with not only parents and professionals, but girls with autism, and talk about social media and dating and the sexuality pieces to really refine these specific items that increase, our girls at really getting into difficult situations in life. So bullying, sexual exploitation, misunderstanding that, sex for love and things of this nature. And that if someone pays attention to them and thinks they're pretty, they like them because of the misunderstanding of the social cues. Psychiatric conditions that we've talked about that are very much comorbid with having a developmental disability or at higher risk in general. And then with females and the rates of depression and anxiety that just raise the bar for having psychiatric conditions. Harmful internalizing behaviors, I think we've mentioned them, but I was always told if something was really important and that you're supposed to listen to and remember, you should say it more than one time. And so These are going to be everything from your eating disorders to your cutting behaviors, to just the suicidal ideations and the feeling of, why am I here? There was a young adolescent, I guess goes together, and the words in which she used were so powerful. I'll never forget. She said, I don't think people know that I'm only 12 years of age. Do you think that anybody knows, and this is not a religious comment, but do you think God even knows that I'm 12 years of age? I don't think that anybody, including God, can know I'm 12 years of age, because if they knew I was 12 years of age, they would never make me have to feel like this, right? So the fact that a 12-year-old can think like that already raises enough red flags for different mental health issues to come, that if they're that robust, and the depression and the kind of feelings of worthlessness are already set in. Academic failure, right? Because of everything's good until it becomes abstract. And when you get into predicting and inferring and the different types of problem solving that are necessary, from math to reading, and then we may be a beautiful writer, can write an entire novel, but we're not necessarily understanding all the words that we're using at that point because they're too abstract. But I've learned how to find a big word that somebody else has used that sounded good, that everybody applauded for, or thought they were smart and popular for, and put it in this perfect conversation so I seem to understand what I'm saying, possibly. And so then on the outside, the teachers may not see that this person has language issues that are coming from not understanding larger, more complex words. When we get into intervention, which we're not going to talk about today, there's an implication for how I engage in, let's say, a cognitive behavioral therapy or an intervention to decrease my risk when I'm not even understanding the concepts because they're too abstract and complex. So this all kind of gives you that upward arrow for risk factors. As you had mentioned earlier, Noelle, the protective factors are things like early intervention services, school-based support, social relationships. And our girls don't get this if they don't have enough of the severe symptoms present early on to be identified to then be referred for services. And so challenges specific to females versus when you're looking at both males and females here are really focused on that sexual vulnerability, same-sex friendships, the feminine self-care, which we haven't really got into, but hygiene and self-care issues, and then obviously the increased barriers to accessing services, different than the risk factors for both boys and girls that kind of go along with just generalized social skills, vocational concerns, and academic skills. So it's important that the literature actually, I'm going to say the name wrong, I'm sorry, but Madamces et al. 2018 really speaks of this very nicely. So in talking about males and females, let's talk about the concept of this perpetuating male bias. And we've somewhat weave this thread throughout the presentation, but we know that most of the research has been based on males. The evidence-based practices have been based on studies that were based on the criteria that was set for males because of the ratios historically being more in boys, and even the biological piece of maybe that the girls have a protective component to not having autism as frequently or in a different way. So that from the diagnostic criteria to the assessment to the intervention, if everything historically, since autism, kind of was identified with the first 11 individuals with Leo Kanner, right, then we have to somewhat rethink these ratios and rethink the lens in which we look through when we have a female in front of us at any age. So is she meeting the criteria, maybe not by the definition of the criteria, but by her definition, her presentation, and how it maps onto the criteria? And to me, this is almost like a whole nother diagnostic training if you're going to be providing diagnoses. some of the licensed clinical psychologists in this area that are doing more and more evaluations on adolescent girls are actually putting in to the reports an overview of autism and how it's different in girls and the research on girls, so that the school systems that are getting these reports are starting to have almost like an educational lesson within the girls' diagnostic report, because otherwise they're still not believing the reports. Right, which is then you get the diagnosis, and this is another part here, because it doesn't match, even if someone writes it in a piece of paper to say yes, people are still questioning it. And this is where we are have such a strong male bias here. So when we're talking about assessment, we need to look at the questions that are asked. And if you're asking questions that really would only be for a boy, I think you had mentioned, no one's ever bought my daughter, let's say, or your daughter, or this person's daughter, or that person's daughter, a train for Christmas. None of the moms I meet say, my daughter, we purchased her trains and dinosaurs to look for repetitive behaviors. That's not what happens. Or if I ask her the question, does your daughter have any hand mannerisms, right? She may say, no, I've never seen that before. Doesn't get scored. Does your daughter look at you when she speaks to you? Yes. Does your daughter look and speak to at the same time? Yes. Does your daughter direct your attention to, realize that you're not paying attention to what she's paying attention, and use gestures and eye gaze to direct your attention to what she's looking at? All the time. Does your daughter, when you cry, does your daughter come and comfort you? Absolutely. She does. Well, none of these questions match, right? And then what we don't see in the assessments are the questions about, tell me how your daughter's play look. What does your daughter's play look like? What is the variety within her play that she has? How does she share her toys with a friend? What happens if you take something or join her play, right? And then, has anybody ever called your daughter or considered what your daughter said as rude or argumentative, or all of these other questions that we've somewhat discussed to this point? They're not included thus far. We'll talk about one or two assessments that's getting better at recognizing the need for female-based perceptions to be embedded, but that is something we almost have to interpret on our own and add to the standardized assessments if we want to identify our girls younger. And then when we talked about intervention, right, if we're thinking about the basic social skills that we need to teach, and you had mentioned that girls are going to be in these peer groups and boys may be more in sports and physical play, and if I learned how to blend in but I can't really get in, and if I get in I can't stay into this group, well then that's going to be, and I'm withdrawing versus being rejected, right, by boys versus girls. My social skills that I'm going to be teaching you are completely different than what I'm going to be teaching a boy, because the experiences in which you're living are going to be completely different. And then you go and you pull a curriculum out and you start to say, okay, well, here's my plan, here's my curriculum-based assessment, here are my goals, and here's my plan, and here are my strategies. And then let's say the girl you're working with isn't making progress. And you've taught her all these great things that she'll never have enough opportunities to actually practice, that completely are, if there's a word, disaligned with her experiences. And so really we get to the place here where our intervention planning becomes like, what is it? Men are for Mars, women are for Venus. They're so divided. There's almost nothing in common, and not all of the same strategies work, because you'll have a girl, if she's intellectually able enough and has enough language, saying, why are you doing this with me? I don't need this. I don't want to do this. This isn't helping me, right? Because of the heightened awareness of what you're doing and why you're doing it, and their own coping skills with accepting their diagnosis if they've yet been told. And so we have to make sure that we look at this. We also have to make sure that when we talk about perpetuating male biases and intervention, that we consider the co-occurring diagnoses that go along with many of our females with our alphabet soup next to their names, and how are we integrating these interventions. So if you have depression and anxiety and obsessive compulsive disorder, and a mental health counselor and possibly a psychiatrist are guiding this, but you have a speech language pathologist or a behavior analyst and a teacher working on the social communication skills, if we're not integrating the conversations and the concerns. So if the girl melts down, do we use a strict behavioral protocol, or are we going more on from the counseling and compassion side of this to allow her to get through it, to then move forward because she was stuck? Is it ADHD because she can't pay attention and she needs this type of support or treatment, or is it debilitating anxiety because of the previous pain history she has, that once mean world syndrome, once it was bad, it's always going to be bad, and I just can't do this and I don't have the coping skills for it. So our intervention typically with a male may be very clear cut and straightforward, not always, but more so than not. When you're working with females, you're planning 6 plans that are fluid and ever changing per the developmental period of that person's life and the day and the situation and the people in which they're with. And they're females at the end of the day. They're females that happen to have all these other things. They're not the other things first. So you're first, the content and design. I think we have to kind of put this all together in a package and be willing to be flexible and innovative and integrate things so that we can move the needle with our females with autism.
It's just a really insightful point. If you don't mind me just throwing just a comment before we move on. And I know getting towards the end, that's so important, and that how much I've learned from you when you're speaking on a topic, and vice versa, I'm sure, from, although we share some disciplines, we have some different of our backgrounds in terms of educational versus speech and language, and how important it is that educators, school counselors, mental health, special educators, speech and language pathologists, continue to engage in a dialogue about this to help each other develop some of these expertise, because as you just very articulated very well, it takes a different level of expertise and understanding to be able to refine these interventions to be impactful for the females that are already delayed in receiving them. So I think it's a very important point that you made, and I just like to punctuate it with how important it is to have these different perspectives, and the educators that are watching this, in addition to all of our interdisciplinary teams, having the same language and the same knowledge, and understanding our own limitations, that perhaps our interventions, we need each other to be able to do them better and more consistently.
I couldn't agree more, and we can definitely move on. I think that humility is your best friend when you're working in the field of females and autism, and being able to always be in the seat of a learner and not an expert. There are some new assessments that have come out. One of them, I believe, is called Autistic Traits Questionnaire, the CAT-Q, which is an online self-assessment that really builds on the shared experiences of adults with autism and masking experiences. And there are definitely treatment advancements that are beginning from working on internalizing behaviors versus externalizing behaviors to consider the gender-specific counseling groups. And we're learning more about what the makeup of counseling groups or support groups for girls should look like, because of the different, gender biases that come into autism and the different needs of females versus males. So I do feel like we're, from the changes in the DSM-5 that we talked about to the changes in the treatment, will hopefully continue to get better at catching our girls earlier. So how do we find at-risk females that are currently eluding diagnoses? This is another million-dollar question, right? And what I think we just talked about that we'll bring together here is bridging the professional knowledge gap.
Sorry about that, I jumped ahead.
No, it's fine. I'm totally good. I'm with you. I hope everybody else is still with us that's watching. And I think we mentioned this, but it's a really beautiful visual to kind of just put it together. And we have to have a mental health counselor or a psychologist on a team with an educator and your clinical professionals, with your doctors and your parents. And I think that someone was talking about an IEP meeting and teaching a parent that they're 50% of the IEP team. And it's such a perfect, I guess, it's a perfect comparable, if you will, to the team for a female that's at risk for autism. If you have everybody talking together and you really take into account what that parent is telling you or that grandparent is telling you, I think that they're the experts in their own children and we are their guides, and not valuing or not really taking in the parents' experiences as clinical information is, I think, a disservice to everybody. So hearing what they have to say, building a story, if you will, a journey, and then taking action. So our mental health counselors are going to be the experts in all of our co-occurring comorbid conditions, right? And then our educators and our specialists are really going to help with, we talked about the executive functioning, the planning, the self-monitoring, the shifting of attention, the problem solving. We want to get into the inferencing and perspective taking. And then looking at the written expression and looking at the comparison to written expression, to verbal expression, to the understanding then of abstract concepts. Because when you actually put that out on the table, if you really lay it out, you see the discrepancies that you can't see in real time. And I don't know that we do enough of that type of in-depth, deep dive into the deep end of the first academic testing and exploration to really truly see what we probably would have seen a long time ago if we started this type of tapping into the educator and specialist form well before the mental health pieces kind of raise their ugly heads or flare up a bit when the masking and camouflaging compensatory strategies break down.